We now go on to the next talk. One of the themes of malignancies in the eye is that they're great masqueraders. And one of the biggest of these is the intraocular lymphoma. And our speakers, we have Dr. Prakash to talk to us about the challenges. And truly, there are many in both the diagnosis and management. And one of the things our session is all about is that malignancies are not either the end of vision or end of the eye. And the kind of results that Fairuz has shown us with advanced retinoblastoma, where in my day they all ended up with enucleation, is truly, truly admirable. So to diagnose and treat, like Vijay is saying, earlier OSS said, chop it off, now no, treat it medically and preserve the conjunctiva. Over to Prakash.
Thank you, ma'am, and good afternoon to all. So intraocular lymphoma is actually a subset of primary CNS lymphoma, and it is, as madam told, one of the commonest masquerade. It masquerades as uveitis, especially in elderly females 60 to 70 years of age, and usually it's a bilateral disease, and it's a B-cell lymphoma, even though T-cell lymphomas are reported. And usually it originates from the retina or vitreous, and that's why it's also called as PVRL, even though there is a few subset which originates from the uvea as well as optic nerve. And also there is secondary lymphoma, which is lymphoma comes from the systemic into the eye. So that has to be differentiated from the primary lymphoma. And if you look at the CNS lymphomas, if they are followed up, intraocular lymphoma develops in about 10 to 16% of cases only, whereas if you follow up intraocular lymphoma cases, nearly 70% of them develop CNS lymphoma. So what it translates to is that it's the onus of ophthalmologists most of the time to diagnose this disease so that a life-threatening as well as a blinding disease is treated in time and saved. So the challenges and the clinical presentation, I will just go through some illustrative cases. So this was the first case. Actually at that time we were not, even though we have read about lymphoma, we were not seeing. This was almost 10 years back. This 65-year-old gentleman presented to us. He had already undergone 2 renal transplants, and he was on triple immunosuppression and had been treated on bone TB. All these things made the diagnosis very difficult for us initially, and we were seeing for the first time the lymphoma, intraocular lymphoma. So these were the lesions, creamy yellow lesions all over the fundus was seen. So the first diagnosis was CMV retinitis given his immunosuppressed status, and straight away started on ganciclovir. But due to the atypical presentation, we did a vitreous tap and sent it for PCR for other viral as well as toxoplasma as well as TB. Only toxoplasma came as negative, and CMV was toxoplasma came as positive, and CMV was negative. So we added anti-toxoplasma also. And even that time we didn't do a biopsy, but 5 days later he presented with further drop in vision. The lesions had grown extensively. At this point of time we thought this could be something else, and we did by this time he actually developed a retinal detachment also. So it made things easier for us. So I did a vitrectomy, removed all this material that you are seeing in front of the retina. And actually, since he had an RD, I could take some subretinal material also, made a drainage retinotomy and removed this material also. And this material, these are very less coercive. They just come when you aspirate, you can see them flowing into your aspiration needle. And immediately it was sent to the cytopathologist, and it was processed immediately, and we could see atypical lymphocytes, and it was diagnosed as primary intraocular lymphoma. Evaluated by oncologists, there was nothing systemic that they could detect, and they didn't start him on any systemic treatment. That's one of the challenges which I will come into later. So this patient we treated with intravitreal methotrexate. At that time we were not aware of the correct protocol also. We injected monthly intravitreal methotrexate. It responded well actually, and I gave it for almost 1 year, and the patient in between he underwent silicone oil removal, and at that time did a cyto again. It was negative. But this patient again presented to the systemic due to CNS lymphoma, and he passed away. The second case again referred to as a probable sarcoid uveitis had this was a lesion in the left eye. You can see these multiple creamy white lesions. Right eye also had 2 or 3 lesions. So by this time we were wiser, and we knew this was primary intraocular lymphoma that we are dealing with. And the OCT, you can see the OCT is very diagnostic of this condition. You can see sub-RPE lesions which are homogeneous. This homogeneous appearance. Many times you see subretinal also, and so these lesions are very typical, and we gave intravitreal rituximab for this patient. And she actually refused systemic treatment in spite of me sending to 2 different oncologists. She refused systemic treatment, and later she was admitted with CNS lymphoma. I don't know what is her condition now. So this was a third case, a younger lady, 56-year-old, presented with some blurring of vision. This was her left eye fundus. You can see these creamy white lesions in the mid-equatorial region. Again, this was very typical of lymphoma. We straight away did the angiography. So the right eye was not involved. There was few RP defects, but there was no lesion in the right eye. Left eye shows angiography shows mixed hyper and hypo areas. And the OCT, again, you can see it is very typical. This sub-RP homogeneous material under the RP with RP, bumpy looking RP. And also you can see the even inner, when it involves, even can involve the inner retina also. When it involves even inner retina looks homogeneous in appearance. This area you can see. And this is a fundus autofluorescence which showed a patchy hypo. ICG showed a blocked fluorescence. So straight away we actually did, since this patient was very apprehensive, I actually decided to do a biopsy, as well as at the same time I gave an rituximab with injection methotrexate. To my surprise, actually the patient developed sudden drop in vision, and there was a CRA kind of picture, as well as a retinal vasculitis, and there was large RP rips at the site where the lymphomatous lesions were there. I don't know whether it was a dramatic response of this lesion. I started this patient on oral steroids, and vision improved to 636 over a period of time, and the macula, you can see the lesions healed well, and the atrophic areas where the RP rip developed also can be seen. That eye became completely, she underwent multiple intravitreal injections of rituximab in that eye. Systemically, again, we even though referred due to lack of specimen, lack of this thing, by many reasons she never could undergo a systemic treatment. And recently I saw her with cataract in that eye. Vision had dropped to 1/60. I was about to advise cataract surgery when I looked into other eye, and other eye is again the same type of lesion which she had in the left eye at this point of time. So now this is actually a retro mode imaging which is seen in NIDEC, which this imaging modality, I was thinking it was useless and I was not at all using this. But in lymphoma, I saw that these lesions are very well seen, much more than any other modality in, so just thought I'll show. So this is the other eye OCT also, similar lesions. So OCT is the most diagnostic thing. So this is again one more case. This patient actually 4 or 5 years back, this is a photo 4 or 5 years back. She had come to us with recurrent anterior uveitis, many recurrent, and vitreous haze has been noted, but nothing else has been noted in fundus. And she had actually undergone, due to recurrent nature of anterior uveitis, she had undergone actually fluorescein angiography, which had this kind of leopard spot appearance in the fundus and some active leaking hyperfluorescent lesions in other areas. So that was her picture. And then 4 years later, she had in between 2 years, there was no follow-up from this patient. Then she came back with this lesion in the right eye fundus, large lesion in the fundus. And by OCT, again, you can see this has involvement of sub-RP as well as overlying retina. Again, you can see that homogeneous lesions all over the retina. So we were diagnosed straight away it as intraocular lymphoma, and biopsy confirmed diagnosis. And this is after multiple injections of intravitreal rituximab. The lesion resolved well with atrophy of retina, but vision didn't improve for that patient. This is the reverse. This was a patient who was already on treatment for CNS lymphoma, who came to us with drop in vision and had this typical lesion. She was a very sick patient. We couldn't do anything further for this patient. So this is CNS lymphoma presenting with ocular symptoms. So the main thing is the vitreous biopsy in these patients. Most important step we have to do is getting an undiluted specimen of vitreous. And if possible, I prefer to, if at all there are lesions, I try to take retinal lesions also. Nowadays, I straight away start with under air. The vitrectomy is done under air, so I get maximum undiluted specimen. Because for flow cytometry, they are asking almost 4 cc of fluid, which you will get only if you do the surgery under air. So this is surgery being done under air. Straight away start with the infusion cannula under air, and this is the subretinal. You can see the subretinal material that also can be taken to add yield. The problem is these cells are very viable unless you transfer this specimen to the pathologist within an hour. You are not going to get it positive for lymphoma. So the quick transport is very important, and we have the problem, we have a lab very nearby, but the oncology people won't take the result from that lab, they want their own result. So that is almost 2 hours from our place, so we find it difficult to transport to the oncology center. One patient has not received systemic treatment only because of that. So now what we are doing is we are cooling the specimen to 10 degree and sending, then our yield has increased even in the oncology, even after 2 hours we are getting positive lymphoma specimens. You cool it for 30 minutes to 10 degree and send the specimen. So that increases the yield of the cells. So other studies are, the most specific is supposed to be the IL-10 bar IL-6 ratio, but nowhere in our place IL-10 is being done. IL-6 is possible. Then you have the PCR for MYD88 mutation that is actually does not require much amount, large amount of specimen, unlike flow cytometry or the gene rearrangement study. Both flow cytometry and gene rearrangement studies require large amount of specimen. So that's again one more challenge, getting the large amount of specimen that is required, as well as transporting in time. So again, treatment over a period of time, we have modified our protocol. Now the intraocular treatment is with IV methotrexate or rituximab, which is methotrexate is given in an induction dose weekly twice for the initial 4 weeks, then weekly 8 weeks, and monthly for 9 months, or rituximab weekly for 4 weeks, and then monthly is being three weekly we are giving. So systemic treatment also is very important in this patient, because we have seen when you evaluate the first time when the patient is having the ocular problem, most of the time CNS lymphoma is not at all diagnosed. Even CSF study, bone marrow, everything is being done, but nothing, you cannot diagnose systemic. Then one day patient presents with the systemic complaints, and then it is beyond salvageable. So that's a problem. So prefer to start systemic treatment as soon as we diagnose intraocular lymphoma. And the prognosis, 90% of them develop some point of time CNS disease, and the survival rate is not very great. And one study shows sub-RP infiltration is associated with shorter mean time to death. So just treating ocular problem alone does not increase the survival of the patient. It's important to have systemic treatment also. So we should remember this disease, and that is whenever you have a patient who is presenting with uveitis, and especially if the patient is elderly, should always think of is it lymphoma. OCT will be the most important diagnostic tool. So earlier treatment, and if you do a vitreous biopsy, you can easily diagnose that, provided you send the specimen very quick and get your pathologist. I keep the pathologist ready there to receive my specimen, otherwise you don't get this positive. Thank you.
Thank you so much, Prakash. We'll take questions at the end.